This is a presentation on breast cancer, specifically breast invasive ductal carcinoma, by Dhriti, Tanvi, Riya, and Harshita. First, we have some general information. Breast cancer is a disease in which cells in the breast grow out of control. The specific type in our case is breast invasive ductal carcinoma. This happens when abnormal cells growing in the lining of the milk ducts change. They then invade breast tissue beyond the walls of the duct. Once this occurs, the cancer cells spread. Breast invasive ductal carcinoma is also the most common type of breast cancer, and there are also different stages. Here we have Figure 1, which is the breast structure of the BIDC. This is the breast, and it shows the milk ducts and how the breast invasive ductal carcinoma affects the space in the duct. Here is Part 2 of general information. This includes stages of breast invasive ductal carcinoma. Stage 0. The cancer is located to your milk ducts. This stage is also known as non-invasive ductal carcinoma in situ. Stage 1. The cancer is spread outside of your milk ducts to the breast tissue. It hasn't yet spread to the lymph nodes. In some cases, the cancer may have spread to your lymph nodes, but not to your surrounding breast tissue. Stage 2. The tumor is small and has to spread to 1 to 3 of your lymph nodes. Stage 3. The cancer is often spread to more than 3 of one's lymph nodes or is causing inflammation of most of the breast skin, but it hasn't yet spread to other areas of the body. Stage 4. The cancer is spread to your other organs, which may include bones, liver, lungs, brain, chest wall, or distant lymph nodes.
This picture here shows the most commonly mutated genes in BIDC, specifically in a trial that we were looking at, but these genes are most likely the ones you'll see in many trials. The ones with an M and a circle around it are driver mutations. These are most commonly found in patients with this cancer. We're going to go more in depth on the next slide. So I just mentioned what a driver mutation is, but I didn't mention what a passenger mutation is, as I did right on the screen. So here in this picture, we're showing the accumulation of mutations. The difference is that driver mutations are mutations that will really intensely affect the development of this cancer, while passenger mutations are ones that are accumulated on the way, not as important to this specific type of cancer, but it will still be damaging. Here's the list of genes we're going to go more in depth in. So we have TP53, PIK3CA, MAP3K1, and GATA3. To start with TP53. So this one's most commonly found on the 17th chromosome, and it's an important tumor suppressor gene, and it's commonly found to be mutated in many different forms of cancer. It's most responsible for initiating apoptosis if the cell is faulty and doesn't pass a checkpoint requirement, so it won't be able to pass these faulty genes and traits on to other cells. The next one is PIK3CA. This one is found on the 3rd chromosome and is primarily responsible for creating a protein called Pd.1 that regulates cell communication as it controls phosphorylation. And this protein acts as an enzyme that allows for phosphorylation. And using phosphorylation, these cells communicate. So it basically allows for cell communication by coding for an enzyme that will use and do phosphorylation to allow other processes to happen through chemical signals. MAP3K1 is found in the 5th chromosome and is known for helping the determination of sex characteristics before the birth, but it isn't the primary way to find out what it is, since this is found on the 5th chromosome, and men and women have the 5th chromosome, while X and Y are what really determines most of our sex characteristics. It also does aid in cell signaling pathways and allows for them to communicate. The GATA3 gene is responsible and is found on chromosome 10 and is responsible for the gene expression in the body, promoting cellular function and allowing these cells to be at their utmost ability and be their healthiest. So while the cell cycle is very complicated, here is a very simplified version of the cell cycle. In this picture that we took from the HHMI website, it shows the different steps and shows the major two steps, which is interphase and mitosis. It also shows the interphase is split into 4 parts: G1, G0, S, and G2. And G0 is an option where it can go that way, but it's not required to. While mitosis is a set of four steps that's considered mitosis itself, and then an extra step called cytokinesis. So G1 phase is responsible for preparing for DNA replication and going through a series of checkpoint requirements to move on. And the S phase is responsible for the DNA replication and also goes through a requirement, and then it can move on to the G2 phase, which is where it prepares for division, for the entire cellular division. And this also has a series of a few checkpoint requirements until it can go on to mitosis. In mitosis, we're going to create 2 new nuclei that all have a set of 46 chromosomes. So each of them have a set of 46 chromosomes that came from an original set of 46 that created 2 chromatids connected to one centromere, making them still 46 chromosomes until they split apart and go into their own respective nucleotides, nuclei. Cytokinesis is the division of the cytoplasm, forming 2 different cells in the end, and it's going to split the cytoplasm right in the middle to create these 2 cells that are now entirely different cells. So what do the genes do in the cell cycle? So I showed you the cell cycle, but the genes really play an important role in these cell cycles, which allows for the development of cancer when these are mutated. For TP53, in the specific form of cancer, it's responsible for initiating apoptosis if the cell does not pass the G1 checkpoint requirements. And so it can move on to the S phase, so it can't continue on with the rest of the cell cycle that allows for cell division. If mutated, it won't be able to do that anymore, and faulty cells can move on. The next one is PIK3CA. So this one regulates the protein that I mentioned earlier, and this is responsible for cell communication, and it's really in the G1 to S phase area where it's responsible, since it's preparing for the division, and it needs to communicate to know that these processes are finished. The next one is the GATA3 gene, and this one functions in the interphase part of the cell cycle, and it really promotes transcription factors from being transcribed and just performing their duty, and they're found in the G2 phase, and usually around the G2 phase, even though they can be found really anywhere in interphase like G1 or G2, but specifically G2 is probably where it's more closer. MAP3K1, this gene promotes apoptosis similar to TP53, and when this gene is mutated, it won't promote it, which means faulty cells will still be able to go on, and this is usually around G2 phase. So I gave you these functions, and I told you they're mutated, but the real big thing between how these genes and the mutation causes breast cancer is that when these are mutated, they don't allow these genes to do their function, and these genes, the things that these genes code for, these proteins, they don't allow these proteins to do their accurate and correct initial function, making it do functions that are not something it's supposed to do, promoting unnecessary cell division. And these mutations will eventually start accumulating while this goes on, making more and more of these unnecessary cell division where you don't want it to replicate, but it still keeps doing that. And we're going to talk about how cells are different from normal cells and cancer cells, how these are different in another slide. But to simply put everything in a few words, the genes, when these are mutated, it can code the proteins the right way and code for the proteins in a way that you will get the right function. So it will eventually affect the cell division process, making cancer cells that will just keep on replicating past a point that it's supposed to. So here are the specific mutations that you would see in some of these genes. So all these genes have various different mutations that could be there, but the ones I'm talking to you about are the most common mutated ones. So in TP53, out of our 814 samples with this cancer, 270 of them had a mutation in this gene, which is a high percentage. But out of those 270, 18 of them had this specific mutation that is called the R175H mutation. This is a point mutation at the 175th amino acid, changing arginine to histidine. The next one is the PIK3CA mutation. Also keep in mind that both of these are driver mutations, as well as the two you're going to see on the next slide. Again, out of these 814 samples, 223 had a mutation in this gene. And out of those 223, 139 samples had the specific mutation called the H1047R/L/Y mutation. And this is a missense mutation, which causes the amino acid at 1047 to change from histidine to arginine or leucine or tyrosine. It doesn't really matter, it's just one of those three. Any three of them will still have a negative impact. And all three of them are the ones that are most commonly found. On the next page, now we're going to show you the next two. So we have GATA3 mutations, and then we have the MAP3K1 mutation. So in the GATA3, we have a total of 814 as well. And 81 of these people had a mutation in this gene. And out of those 81, we had 20 samples that had the specific mutation of X308 splice. A splice mutation in this place is where the mRNA or the DNA has a mix of introns and exons that are not in its proper places, and it's just a big mess of everything going on. And in this one, the GAT3 gene, for this specific mutation, at the 308th amino acid, there is like an unidentified amino acid that's like all jumbled around in these exons and introns, causing a problem. And this wasn't specifically studied to see which amino acid it was. We don't know which one it is, but we know that there was a problem there. Then on the MAP3K1 mutation, we have a total of 814 again, and 58 of these samples had a mutation in this gene. And out of those 58, we had 5 samples, which was the highest amount of similar mutations, that had the R763 CFS35 mutation. I don't know entirely how to pronounce that, but I think that's right. And this was a nonsense mutation that made the gene stop having any more codable base pairs at the 763rd amino acid, changing arginine into the termination point. So arginine was changed into the termination point, cutting down the rest of the sequence responsible for a lot of the cellular function. As I mentioned earlier, now we're going to show you the difference between normal versus cancerous cells. To begin, cancerous division, if we're talking about the division itself, in this picture, in figure 12 as we show here, it's just driven by too much cell division and too little cell death. There's nothing allowing it to stop dying, but there's so much that's allowing it to keep going. And these are some of the proteins and things that I listed on this page, showing tumor inhibitory suppressors like TP53 and stimulatory proteins that promote more cell division. So when these tumor suppressors are weak and not unable to do their job, they will cause too little cell death. And then when these stimulatory proteins are producing so much and stimulating way too much than it's supposed to, it will cause too much cell division. And when cancer cells basically misuse these mutated genes, as they're mutated and they're going to do wrong functions, and they cause this insane growth, and it will keep growing into a tumor, which eventually might grow into something cancerous and develop BIDC. In figure 11 here, we show a chart with the differences, and it kind of shows how the shapes are really different, how these cells are a little more organized than normal cells, while cancer cells is just a big mess of a bunch of mutations, and how they look very different. To summarize what I've been saying so far, mutated genes will affect the proteins that it creates, causing problems, as in what I've showed on this, suppressors and stimulatory proteins, and will eventually allow for the growth of cancer. And the genes we showed specifically allow for the growth of breast invasive ductal carcinoma. While these genes can apply for other cancers, for this cancer, all those genes are really important in causing.
What are the risk factors of invasive ductal carcinoma? So one of them is inheriting a mutation from your bloodline. Breast Cancer Research Foundation says that 10% of breast cancer is caused by inheriting genes. Having a family history, such as a woman in your family tree who has had breast cancer, puts you at high risk. Being overweight and being over the age of 55. Being over the age of 55 is a risk factor for breast cancer because as we age, our bodies undergo natural changes that can increase the likelihood of developing cancer. Additionally, there are hormonal changes that occur during menopause, which also contribute to an increasing risk. Late menopause is considered a risk factor for breast cancer because women who experience menopause at a later age are exposed to higher levels of estrogen for a longer period of time. Estrogen can stimulate a growth of breast cells, and prolonged exposure to estrogen increases the risk of breast cancer. Radiation to the chest, as well as smoking, is considered a major risk factor, as when you smoke, it may lead to DNA methylation, which causes changes in your DNA, which leads to a mutation, which also happens to be one of the ways that cancer happens. DNA methylation can lead to changes as when a methyl group is added to a specific region of DNA, it can affect the way genes are turned on or off. This impacts the production of proteins and other molecules in your body. Drinking alcohol, and especially having a personal history, such as if you have had breast cancer on one breast and you're cured, there is a high chance that it will happen to the other breast. Global distribution. Figure 13 shows the incidence and mortality rates for breast cancer in the given countries. It shows that Australia and New Zealand have the highest incidence rates, while Polynesia and Melanesia have the highest mortality rates. My source for this is Cancer Atlas. Figure 14 shows the breast cancer cases in each country and the incident rates of each country compared to the world data. It shows how high the cases in some countries are and how low they are in some countries. Some countries that have the highest amount of breast cancer cases are Canada, America, Australia, and New Zealand, and some other ones. China and some countries in Africa have the lowest amount of cases. Figure 15 shows the cancer cases of 2023, and it emphasizes how large the amount of breast cancer cases are compared to the rest of the cancers. Figure 16 shows the different types of breast cancer and their incidence rate. It shows that the type of cancer we're doing, invasive ductal carcinoma, is the most common type of breast cancer that happens both in men and women.
Multiple symptoms that can occur if you have this type of breast cancer. Some include swelling, pain, two different types of pain, breast and nipple pain, dimpling, skin irritation, redness and scaliness, all up near the armpit, inverted nipple, thickening of the breast or nipple, and discharge that is in breast milk. That can be seen in figure 17. And the arrows from the symptoms to figure 17 show which specific symptoms may be seen in figure 17. And if any of these symptoms are occurring, you most likely have breast inductive ductal carcinoma. For treatment options, there's the main three: surgery, therapy, radiation therapy, and systematic therapies. And the survival rate increases if you're diagnosed within 5 years, and if you're diagnosed after 5 years, it drops. For surgery, there's a lumpectomy, and mastectomy. In the lumpectomy, as seen on the right, they cut a little incision to get the tumor out, but in the mastectomy, as seen in figure 19, they cut off the whole thing. Radiation therapy, high energy X-rays, protons, and other particles kill the cancer cells. And external radiation, the radiation is delivered from outside your body. And in internal radiation, after you have the surgery to remove the cancer, the doctor can temporarily place a radiation device in the breast area where the cancer was to help protect after the treatment. And figure 20 shows what radiation therapy may look like for external radiation. Systematic therapies are chemotherapy, hormone therapy, and targeted therapy. Chemotherapy deals with drugs and pills, and they act on the S phase of the cell cycle after taking the chemotherapy medication. And hormone therapy works by decreasing or blocking certain hormones that help the cancer cells. And targeted therapy uses medicines that are directed at target proteins on breast cancer cells to help them grow, spread, and live longer. They work to destroy cancer cells or slow down their growth.
Here we have clinical trials. How is the breast invasive ductal carcinoma diagnosed? Well, there are 4 methods, one of which is physical exam, a manual examination of one's breasts by a doctor that can detect lumps and other changes. The next way is digital mammography, which is electronic images that are developed to show the inside of the breast to spot abnormalities. Next, we have breast ultrasound. This uses sound waves to examine the breast tissue and gauge blood flow. And finally, we have breast MRI. This procedure uses a large magnet radio waves and a computer to detect small breast lesions. Clinical trials for breast invasive ductal cancer include the examination of the likelihood of progression from ductal carcinoma in situ to invasive breast cancer in women with low-risk ductal carcinoma in situ, who undergo either watchful waiting, which means no surgery, or standard care, which is surgery. Here we have figure 21, which shows the progression of cancer. This picture shows the development of breast invasive ductal carcinoma, starting from a healthy duct all the way to an invasive ductal carcinomal duct. Here are clinical trials from the past that are currently used. There are 3 ways, one of which are lumpectomy, a surgery which is used to remove cancer from the breast. Only removes the tumor and a small rim of normal tissue around it. After a lumpectomy, the breast looks as close as to possible as it did originally. Another method is mastectomy. This surgery is advised only if the tumor is large and if the tumor involves more than one area of the breast, a surgery to remove the breast. The risks of mastectomy include short-term breast swelling, breast soreness, wound infection or bleeding, and swelling of the arm if lymph nodes were removed. Radiation therapy is used often after a lumpectomy to ensure all cancer cells are destroyed to prevent cancer from occurring once again. It is not advised ever after a mastectomy. New clinical trials are being developed, one of which is olaparib, which is a drug that used for people who have primary breast cancer and inherited the altered BRCA gene. Another drug that is being developed is the trastuzumab deruxtecan for patients with HER2 positive secondary breast cancer. Here are some fun facts, rather informational facts. An estimated 297,790 new cases of invasive breast cancer will be diagnosed in the US. It doubles in size every 180 days, or about every 6 months. It consists of 80% of all breast cancer diagnoses. It is one of the most aggressive types of cancer. On average, 7% to 11% of women with early breast cancer experience a local recurrence 5 years after having the disease. In rare cases, the causes of invasive ductal carcinoma have been traced to inherited factors. Most women choose to do a mastectomy rather than other treatments. Doctors do not generally give radiation therapy twice due to severe adverse effects. Here are our sources. Thank you for watching. Bye!